Well, good morning and welcome to the Cutting Edge Conference. This is a conference that's been proudly put on by the College of Nursing at National Yang Min Chiao Tung University, and I'm very grateful to be a part of it. So I'd like to express my warm gratitude and thanks to Professor Shuzhu Chong, who's the Dean of the College, and to thank you all for the opportunity to speak here with you today. As you can see from the title slide, I'm staying on the focus of the cutting edge, but I'm looking specifically at implementation science and the power of nursing data ownership in knowledge translation. Now, before we get too far into the talk, a little bit about myself. I'm an associate professor at the University of Adelaide in JBI, School of Public Health. I'm the deputy director of JBI, but I'm also the program director for implementation science. And you can see my affiliations in regard to Twitter and to journal editorial work on screen as well. So I wonder what you think about when you think about the cutting edge. It's a very specific term, isn't it? Being an academic, I turned to the literature to see what it has to say about the cutting edge in nursing. And I think, that's a natural response, a natural way to get started in thinking through a new topic, is to have a look. What does the literature tell us that it is? And is that something we want to discuss and talk about? So then it was interesting. I found this paper, a global output on artificial intelligence in the field of nursing. And it was a mapping process, essentially. So they looked at what's out there, what's been published, and developed up this bibliometric analysis and reported it for us. So what did they find? What did they say is cutting edge nursing technology? So in a bibliometric analysis, you observe and record frequencies or incidences of terms and terminology, and then you can cross-compare them with dates, such as year of publication. And that gives you a map of frequencies around terms and how they emerge over time. It's a good piece of descriptive work. It helps you see what people are talking about, when they're talking about it. So it can be helpful for trends. And if you wanted to know what the hot topics were in 2022, this is the list: nurse rostering, diagnosis, decision support, disease risk factor prediction, big data management, expert systems, support vector machines, decision trees, deep learning, natural language processing, and nursing education. Do you find this list inspiring? Do you find it surprising? Did it seem like old news and you've checked off most of these items, or are they unfamiliar to you? Technology has an influence in all these aspects of nursing informatics, and it has an increasing role in other dimensions of nursing as well, such as education through simulation training and a number of other areas. It doesn't feel very cutting edge, though. It's not quite the quantum leap that might solve multiple concurrent, intractable, complex nursing problems. And I'm not sure if that level of cutting edge technology has even been developed yet. Maybe you'll hear from someone else later today that it has. Is nursing technology the cutting edge? If you think about what it's referred to in the literature, these are not particularly new to you, I'm sure. Wireless rehab tech has been around for quite a long time. Simulation training and education became much more used during COVID, but has also been around for quite some time. And a lot of this tech has been around since I was a clinician a very long time ago. But you can see what's occurring in the literature, right? You get the picture here. There is a link between technology and the cutting edge, which is almost inseparable. The literature focuses on the role of technology in pointing toward the cutting edge. Yeah, a lot of what it talks about in relation to nursing feels like slightly old news. However, if you consider it, the cutting edge, yes, it has its information technology or its AI connotations, and rightly so. That's where a lot of innovation and benefit has been derived, particularly for nursing practice. It's empowered and it's enabled good due diligence and decision making. Information technology has given policymakers more rapid access to information and data than they had previously. And this has meant that policy can become responsive almost in real time to emerging trends and changes. And personally, I've lived through that experience as waves of COVID infection were predicted, anticipated, modeled, and public health measures were put in place to anticipate managing peaks to level them off and managing troughs to try and sustain them. But at the same time, there's got to be more to the cutting edge than intravenous pumps and electronic health records, doesn't there? It's just something about it. It just needs a little bit more of something. And others have thought the same. To be at the cutting edge could represent more than one perspective. Sure, you can be at the forefront of technology, but it could represent being world leading on a professional basis. So it can represent more. It can represent not just innovation from a technology perspective, but it can represent human innovation or the reimagining of existing knowledge. It could even be pragmatic rather than quantum leaps. And so for today's talk, I'm taking this slightly different perspective on the term cutting edge. This quote by Jacob Borowski inspired me to reconceptualize the cutting edge altogether, because he said the hand is the cutting edge of the mind. And as a nurse myself, there's something about that I find innately appealing. Jacob Borowski was a lecturer at Yale University, and he lectured on the role of imagination and symbolic language in the process of discovering scientific knowledge. He was a genius, and he had this perpetual sense of curiosity about the world and an interest in the human condition. This was his saying, the hand is the cutting edge of the mind. What did he mean, though? And how does it relate to our talk this morning? Well, to find out a bit more, we've got to go exploring. So we're going into something called blue ocean strategy. In the picture on screen, you can see a small boat on the crest of a wave. The crest of the wave visualizes where innovation occurs. It visually represents where leaders want to be. It's at the forefront of movement, driving and anticipating, rather than back in the pack where it's crowded and competition is most fierce. The concept of blue ocean strategy comes from marketing literature, and it's defined as a process of exploring. Blue oceans are vast, deep, and powerful in terms of opportunity and growth. Blue ocean strategy is this process of simultaneous pursuit of differentiation and low cost in order to create or open up new opportunities. It's about identifying or creating and capturing uncontested space. And I think nursing needs uncontested space that it creates for itself. Uncontested space makes the opportunity invested both low cost and high return. It's based on the view that boundaries and structure are not a given. They can be reconstructed by actions and beliefs, things which Jacob Borowski might call cutting edge processes. And when we think like this and do this, it creates new demand and opportunity for new lean products that fit a new or an emerging market segment, often before the market even knew that it wanted that product. So you can see the blend of pragmatic and market language here. But there are some interesting non-market connotations or connections to nursing education, to implementation science, and to knowledge translation through nursing data. And that's what I want to explore with you this morning. So here's the basics of blue ocean strategy. It's not simply about rethinking, it's about first principles for an entire approach. It means employing our expertise in our materials in new and untapped ways. What might a blue ocean strategy look like in nursing, given existing system constraints and the needs and priorities of the profession? There's many aspects where this concept could return low-hanging fruit of value. But this talk is about implementation science and data. So the question I ask is there a blue ocean opportunity in the way we consider and use nursing data for evidence implementation? To answer that question using blue ocean strategy is to go back to first principles and evaluate the gaps in what we currently know about the use of nursing data for evidence implementation. So we start with the innovation and ask, what do we know about it already, to consider where innovative room for improvement might sit. So let's take just a few minutes to recap what might be existing knowledge for you in relation to implementation science, audit, and feedback. And that's because the basis of blue ocean strategy is to start with a known and look afresh at how it's being used to determine what are the gaps here. Do we have capacity, intent, interest to re-engineer or redesign the process to accommodate new and emerging needs? If so, how do we improve capacity and empower nursing data ownership in knowledge translation? So we're going to start with this very familiar process of audit and feedback to look at the bigger picture of how we can capacitate the power of nursing data in knowledge translation. So the first question is, of course, is it an effective intervention? Well, what does an old review? This is a summary of a Cochrane review from 2012 on the effectiveness of audit and feedback. And so what does this old review tell us about cutting edge knowledge translation? Well, you can see the data on screen, 82 comparisons from 49 studies with a weighted mean adjusted risk difference of 4.3%, showing an absolute increase in compliance with the desired or preferred practice. And 26 comparisons from 21 studies on continuous outcomes with a weighted median adjusted percentage of 1.3%. So this data tells us that audit and feedback generally, and this is across around 60, 70, 71 studies. Audit and feedback generally leads to small but potentially important improvements in professional practice. The effectiveness of audit and feedback seems to be dependent on some characteristics such as baseline performance and how the feedback is provided. So you can see the regression analysis results. What they sort of suggest is that if you give feedback as in the presence of low baseline performance, or if the source of the feedback is a supervisor or a colleague, if you give that feedback more than once, so repeated messaging in multiple modes, in other words, not just verbal feedback, but maybe verbal plus written or reminders. And this is the interesting bit, when you add to the feedback process targets and action planning, then you got more consistent change processes. So what is it about audit? Well, nurses know and have experience with audit. So one of our questions is, are there possible blue ocean gaps in audit that could enhance the power of nursing data ownership in knowledge translation? Well, there are hints that the answer could be yes in a 2020 BMJ paper, where audit and feedback was described as offering explicit standards linked with implementation science and the capacity for embedding research. The benefit of explicit standards is that they help address weaknesses in attempting to engender practice change, particularly if there is a gap in the evidence around or underpinning that standard. Strong standards for evidence-based practice change are based on evidence and if you're familiar with the JVI approach, you'll know the evidence is the basis of all the practice change standards we use. So evidence-based standards can be used as a gatekeeper of quality and are associated with improved uptake of change processes. And that's something useful to keep in mind. Implementation science offers us theory-informed mechanisms of change to promote uptake and sustainability of practice change, although it's barely been investigated or explored in the International Joyner-Briggs collaboration. And even in the broader international literature, it's not that well understood from a nursing perspective. In other words, there's a lot of research going on, but nurses and nursing data are not central to that research in relation to having explicit standards in audit and feedback, in integrating elements of implementation science in audit and feedback, and in the ability to develop and embed research agendas that advance our knowledge of the methods of audit and feedback. This work is already happening, but it's not driven by nursing data and nursing implementation. So this is the challenge that we're going to come back to a little bit later in the talk. So right now, what we've seen is audit and feedback is effective. It leads to small but important changes in professional practice. Is it cost effective? In other words, should an organization invest the money into establishing routine nurse-led audit and feedback programs, or is that poor use of money? So here's an important question for us to consider. And there is a BMJ paper on this from BMJ Safety and Quality. Overall, this one study, as you can see, included quite a large number of economic evaluations. And in fact, it looked at 24 audit and feedback interventions. It looked at de-implementation. It looked at targeting disease management, prescribing, disease prevention, screening, vaccination, radiological imaging. And then there was a range of interventions that were also included based in hospitals, hospital wards, clinical practices, or health professionals more broadly. So as you can see here, in one section of the review, they looked at 35 economic evaluations, and audit and feedback was more dominant in 7 and less costly when compared with control in 5, and equally effective but less costly in 1. And then across 8 cost utility studies for which there was a measure of net health benefit, the audit and feedback intervention was favoured in 7 out of the 8 interventions there. So this then suggests to us that audit and feedback has high potential to be cost effective, especially when measures of effectiveness related to health outcomes and to costs that go beyond that of the direct intervention are considered within the bundle. And that comes down to the fact that there is significant capacity for change and quality improvement in audit and feedback. So these might be things you already know about. But how might we really revitalize audit and feedback as a blue ocean strategy to stimulate further uptake and further investment of nursing time to obtain more nursing specific data to help us drive our own safety and quality agenda in nursing forward? Well, there's been a number of suggestions, and we've looked at standards, we've looked at embedding those, and we've seen there's room for a research agenda here. And that's what I want to just show you for a minute now, is just a couple of little points related to what does a research agenda look like in audit and feedback. These are things that we don't generally see in the nursing literature. So here's just an example. This is based on a United Kingdom project. So it's in the NHS, or National Health Service. and they've been doing some evaluation work of their national clinical audit programs. And the main program that is reported on screen here for you is related to the measurement and improvement of structures, processes, and outcomes of stroke care. So this is not intrinsically a nursing question, but my challenge to you as the nurses here today is to think about what is the nature of the questions that you're asking when you think about audit and feedback and evidence-based implementation driven by nursing data. Are we thinking at the level of the patient? Are we thinking a little bit bigger? Are we at the level of the organization? And then my question, I guess, is where is our leadership going to take us in terms of the scope and scale of audit projects that really demonstrate the impact of nursing data at a national level? And that's what this is hinting at here, this blue ocean concept, moving nursing data onto the national scene rather than within our traditionally smaller scale work. So this is the evaluation of a national audit program, and I would love to see some work like this emerge in Taiwan as well. It's a continuous centrally arranged audit, so the data is continuously collected and they're able to demonstrate particular outcomes which are important. Stroke unit performance in key aspects over 5 years. So the proportion of patients assessed by a specialist within 24 hours. And they can put a number on that and say, we improved this outcome from 74 to 83%. We can put a number on the fact that nutritional assessment by dietitian rose from 66 to 81%. These are significant benefits to be able to claim for a profession. Yet we can't claim these for nurse-led audit and feedback, and we can't claim these yet for nursing data in knowledge translation. Because while we have some national framework driven audits going on, there's a question around who's using that data to draw what kind of pictures. And there's strong policy links from that data, but I think there's less impact links from that data than we could potentially be benefiting from. So impact links is what I think is the blue ocean space for nursing data, because not a lot of measures of impact in and outcomes from nursing data. But the second component was about embedded research within the process. And when you think about the way audit and feedback's done, you often have this combination of clinical people plus academics plus policy and governance. It's a multidisciplinary project each time. So we've got the capacity to embed research, but at the moment, nursing is not enabling and delivering on the embedded research activity within ongoing or continuous audit and feedback cycles. So we're actually missing out on this blue ocean opportunity to generate new nursing data and new nursing knowledge associated with the use of audit and feedback for knowledge translation. You rarely see this in nursing. This is a randomized controlled trials conducted in parallel with audit and feedback to assess the effect of adding an implementation toolbox, which is eminently sensible. That's what the JBI approach is based on. Here is specific to the quality of pain management in ICUs. 21 Dutch ICUs were randomized to intervention or control. And then over a 6-month period, they measure variation in differences across those units for pain management. And again, you can see there's a significant difference there, 14.8 versus 4.8% in the feedback group. So these are two spaces already where it fits a blue ocean perspective. We just haven't moved there. And I wonder why that's the case. I think partly it's this. So nurses are employed by organizations, normally in, group construct bases. So nursing data, it's not very individualistic, and maybe that's a problem. But also nursing data is organizational data. So nursing data is owned by organizations, not so much by nurses. So it's used primarily to facilitate organizational management of the nursing workforce. That's ideal, right? We need that. We need nurse-patient ratios. We need to manage rostering and complex systems and make sure patient needs are covered 24 hours a day, etc. But we're more than a workforce. So hopefully this is a slightly provocative statement. It's actually meant to be, even though it's not entirely correct, because we work in organizations and we collect, and act on data all the time. But I wonder whether most nursing practice is meaningfully informed by organizational data. And I don't think it is, although you can answer this question in your context better than I can answer this question in your context. To what extent do nurses providing patient care receive relevant information that informs the structure, function, and delivery of care for improved patient outcomes? There's a question for you. I'm the editor-in-chief of JBI Evidence Implementation. I read 50 to 60 implementation submissions a year. None of them routinely include organizational data on structures, processes, or outcomes of nursing care as a justification for the study. So that's interesting. We have to ask the question, are we doing nurses a disservice if they don't have access to relevant data for their professional practice? You see, knowledge translation is an opportunity for nurse leaders to create and to attribute nursing care data as an indicator of professional practice. And historically, nurses have relied on systems and organizational information. So nursing is being considered a cost rather than as a data-rich field of professional practice. So the blue ocean question is, how do we move away from that and see the hand as the cutting edge of progressive incremental change? Well, I have 4 suggestions to see us through, hopefully for the rest of this talk. The first is to think about widespread adaptation, organization, and organizational recognition of evidence-based healthcare decision-making. How widespread is this across Taiwan? Widespread adoption and organizational recognition of evidence-based healthcare decision-making. What about the provision of a national point of care resource specific to the knowledge needs of nurses in policy and practice? Does that database exist of evidence for policy and practice? Is there capacity to have a pivot to meaningful nurse-led data collection, analysis, and ownership? Is that already there and there's some rollout needs that have to be taken care of? And are there opportunities to participate in knowledge translation for nurses that are creative, that are compelling, and that are clinically relevant? So let's have a look at these 4 suggestions that could take the use of nursing data in order and feedback into a knowledge translational process. Widespread adaptation and organizational recognition of evidence-based healthcare decision-making. I mean, there's some questions to ask here. How embedded is evidence-based healthcare in Taiwan, across Taiwan? Is it in the role and position descriptions for nurses? Is it capacitated in terms of funded access to resources at the point of care? To what extent throughout the nursing career ladder are there opportunities to engage in evidence-based healthcare as professional practice? And are those opportunities available? Do they integrate between the clinical, the academic, research, and scholarship components of the nursing profession in Taiwan? So what strategies inform the uptake and the use of evidence in practice by clinicians? And to what extent is nursing being moved to lead routine evidence-based healthcare? I think the answers to some of those questions are important in thinking about the adoption and organisational recognition of evidence-based healthcare decision-making in clinical care, whether it's acute or primary or community. The second issue is around the provision of national point of care resources specific to the needs of nurses in policy and practice. So we all need evidence, but we need specific evidence at specific points in time, which means we need a large data set of evidence summaries and summarized, critically reviewed information to help us with clinical decision-making in an effective way. If that resource is available through a library, but not at the ward, then it will be underutilized. We know there are issues of accessibility when information is limited to a library service as compared with when it's available on devices, BYOD devices or portable devices, and in wards. Nurses in clinics, nurses in cars, nurses in community service, they need a consistent high quality resource to meet identified knowledge needs and be able to provide standardized evidence. Now remember that term, well, evidence standards, that was from the BMJ review we looked at the start of this talk. So there is a lot of congruity between the needs and information systems that could be helpful to us. So some questions to consider if you want to get passionate about the cutting edge of nursing data. Is evidence available to nurses at the point of care? Is there a national standard for this evidence? And is it consistent across the sectors where nurses provide care? And those are important things for you to think about going forward, I believe. What about meaningful nurse-led data collection, analysis, and ownership? So first of all, to acknowledge this slide is courtesy of Professor John Lavis and the COVID-19 working group, of which I have been a member actually for just a bit over 2 years, although that group is winding up now and transferring to something else. But what you can see on screen is that we have a lot of systems. There is potential for integration, but the fact that there's potential for integration also means that there is potential for de-integration or for loss of integration. We've already talked about evidence information system available for nursing, able to be used across sectors, and that's an enabler of other ongoing complementary activity, promotion, and data collection. Where that kind of content is embedded and in partnership with an evidence implementation system, and that might be a systematic, coherent national framework for audit and feedback, and why wouldn't it be? That would be a brilliant strategy. Then we start to get increased congruity and complementarity between our systems. So, reading from a Western perspective, we read left to right. Evidence support system enabler complementariness to other multiple systems. Evidence implementation system. What's it going to connect to? It doesn't get across into our research and innovation systems. Okay, so there's disconnect here. And our research system is somewhat but loosely tied to evidence implementation, but disconnected from innovation. So how do we get these things more connected in order to have a kind of comprehensive approach to managing this process? Well, we need to incorporate evidence use into routine advisory and decision-making processes to help us build and sustain an evidence culture where we have transparent requirements for evidence inputs into decision-making. We want to be able to strengthen capacity for evidence use, as well as broader policy and program capacity amongst policy and practicing staff. And that includes advisors to government, government policymakers, expert panels, not just nurse practitioners, but the entire spectrum of the nursing profession. And we want to have mechanisms at the interface between the evidence demand and supply sides to ensure that we're prioritizing evidence-based decision makers' needs and the information needs of advisors to health policy and practice. If we have the right evidence implementation system, then we can package evidence from multiple sources into inputs that align to the actual requirements of advisory and decision-making processes. And in terms of evidence support units, we need to understand our own domestic context, what the required evidence standards are, and decision-making or decision-makers' preferred communication formats are, so that we can provide timely and demand-driven data, advice, and evidence-based information that focuses on information within context, so our local context. And if we have these, then we are able to address the domestic demand for evidence by drawing on international collaboration and a global evidence base for given decisions in a way that's more likely to lead to equity-sensitive outcomes for the quality and delivery of patient care. So let's have a look at an example of how that might come together. And I'm going to try to wrap this up in about the next 5 minutes for you, but we'll see. You're familiar, certainly, I believe, with the JBI model and how we move from conceptual model of evidence-based healthcare into planned action. So without laboring over that, this is thinking about moving nursing data using a blue ocean strategy by taking pragmatic phases of the evidence implementation approach and designing and developing specifically for the implementation of this, but at a broader level, embedding the evidence, embedding implementation, and embedding research frameworks as well. So this framework provides the structure, and here's the example of that. It's a look at using evidence such as from meta-analysis and integrating some of that into clinical care standards that could be used as part of the audit process. That helps to inform what it is we're going to implement and how we're going to implement it. So you can see a JBI evidence summary has been developed on the basis of multiple other existing forms of evidence to provide a critique of that. And from that, we develop audit criteria where the sampling framework is specified there in parallel to the criteria. So is it patients? Is it healthcare workers? And this will vary from criteria to criteria. Some criteria are specific to patients and patient outcomes. Some are specific to nurses or other staff within an organization. So what sort of sample size and sampling framework, and then how is compliance going to be measured? So that's not blue ocean. That's what you're used to. That's the normal audit process, right? So we can take any number of key points and criteria, review current practice. So as you can see on screen there, we're up on phase 4, reviewing current practice against evidence-based criteria. So these are the criteria that were developed in order to inform an audit and feedback project. And then once you've done that review process, you want to look at what were the barriers to improved compliance. So we've already seen audit can improve compliance, but this is more of an illustration of the analysis of those barriers and use of nursing data to inform the thinking about practice change. So you can see the barriers for the health professional and the organisational level there, but also what are the interventions that are going to help us bridge those gaps or those barriers. And it was around the role of education, reminder systems, which we talked about right at the start of of this talk, and as well as a number of tools to support the implementation process. Then, of course, there's this reassessment, this reevaluation, and it shows you your pre and post data. Now, we have many examples of this from Taiwan. There's the JBIC Center in Taiwan, led by Professor Pei Fan Mu, does a very superb job of undertaking this work and demonstrating the effectiveness of nursing care. And so, you're not surprised to see this kind of data that shows the impact of nursing intervention practice, I'm sure. So I guess the question then is, where is this going to head next in terms of thinking about it? When I looked up Taiwan, you rank 13 in the world, well, in 2022, for healthcare innovation. And the two things that were prioritized in that assessment were the use of a single payer system, although that might be complicated, and the innovative approach to digital health records. I think that's the bit, the innovative approach to digital health records. This is where there is a bigger opportunity for nursing in Taiwan, an opportunity to go blue ocean by partnering together across clinical, academic, government departments to go blue ocean on the use of nursing data to demonstrate national level impact. So that's the kind of the thought I wanted to finish with and leave you with, is thinking about what do the strategic priorities look like to get there. We know leadership requires ongoing training, support, and development opportunities in order to build skill sets rather than be presumed to have skill sets. But we also concurrently need to build expertise through projects and capacity building initiatives. And I think that comes from partnering together in bigger, more substantive nurse data generation, nurse data management for and by the nursing profession to improve the quality of care. And once we have some cycles of larger nurse-led projects, we can start to better understand the translational pathway from big picture nursing data into demonstration of quality of care and impact on patient outcomes for nursing. That, I think, is the synopsis of ultimately where we would hope to be able to head with this kind of information. So I'll just pull up a few references for you as well. But apart from this, I just wanted to thank you again for the opportunity to give this talk. I hope you've enjoyed it, and I look forward to the questions to come. Thank you.